it's on the onus of the chiropractic profession to recognize that these patients and the challenges they face in traditional modern medicine and resorting to chiropractic treatment, wanting to help them, but also knowing the risks of manipulation, that's where they can get themselves into trouble too with really hurting people.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in connective tissue disorders like the Ehlers-Danlos syndromes, dedicated to helping you navigate joint hypermobility and live your best life. Today, we'll be speaking with neurosurgeon Dr. Betsy Grunch. Oh my gosh, I just looked out my window and saw this incredible double rainbow, so now my ADHD is kind of kicking in. But we're going to have a great conversation. As you know, I've already spoken to a number of different neurosurgeons, and it's so important to have these conversations because neurosurgery is a very, very big decision, and you want to make sure that you are making the best possible choices. It is possible to have symptoms without really having findings on imaging to explain the symptoms. And likewise, you can have findings on imaging that possibly correlate with the symptoms, but not always. So it's really, really important to gather as much information as you possibly can so that you can make the most informed decisions. Dr. Betsy Grunch is a board-certified neurosurgeon at Longstreet Clinic in Gainesville, Georgia, specializing in minimally invasive spine surgery and neurotrauma care. Honored as a top doctor by Georgia Trend and Atlanta Magazine, she was named one of Atlanta Magazine's Women Making a Mark in 2023. Known online as Lady Spine Doc, Dr. Grunch shares her expertise with millions of followers, simplifying neurosurgery with content that educates, inspires, and connects with both medical professionals and the public. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Oh my gosh, I am so excited to finally be here with Dr. Grunch. We have had computer issues, software issues, emergencies like this. I feel like this is a long time coming, so I'm so happy that we're finally sitting down to chat.
Yes, absolutely.
Oh, I'm so happy. So can you start out by telling us your journey into neurosurgery and briefly, how you ended up here?
Yeah, it's been a wild ride. So first off, I have to apologize for my raspy voice. I have a little bit of laryngitis, so I don't normally sound like this. Basically, I think everybody that goes into medicine kind of has some type of draw or something that led them to the field. For me personally, it was I was a teenager. I was in that time of my life where I was kind of trying to decide what I wanted to do when I grew up, and my mom was involved in an accident when I was a freshman in high school, and she suffered a spinal cord injury, and so that kind of catapulted me into the healthcare field, in terms of just kind of going through her rehab and recovery and trying to understand like why something like that can be so devastating. So her journey with her surgeries and recovery really fascinated me about neuroscience, particularly about the spine, and and eventually led me to where I'm at today.
Yeah, you're right. I think so many of us have a personal story that really impacted our path. So it's always interesting to hear. And do you have any direct experience treating patients with connective tissue disorders like EDS? And if so, what led you into that space?
I mean, I think being a spine surgeon, naturally speaking, like people with connective tissue disorders have spine disorders.
Right.
So yeah, I mean, I have a pretty broad experience. And then, of course, being the fact that connective tissue disease and autoimmune disease are kind of more prevalent in females, and myself being a female healthcare provider, I think naturally, I see a fair amount, probably, I would venture to say more than normal, of patients with these types of processes.
And if you were to explain to another neurosurgeon who's not familiar with connective tissue diseases, not familiar with EDS and in particular hypermobile EDS, how would you explain that to them?
Oh man. So I mean, I think that anybody that doesn't understand or appreciate that this is an entity that they need to be knowledgeable in. I think it's, the way I like to describe it is I think we as surgeons and particularly we look at images and we make decisions based on static images. And the thing about hypermobility disease is it's not a static problem. So, like, you know, people, our bodies are meant to be in motion, and we're forced, in particularly in my field, of having MRIs and X-rays done in one moment in time, and
Mhm.
it's so difficult to sometimes really conceptualize what may be going on outside of that image and what, and trying to conceptualize how to interpret that, how to treat that, and how to manage it.
Yeah, no, that makes sense because dynamic imaging would be preferable probably for anybody, but especially for people with connective tissue disorders, right?
Yeah, I
So
mean, like, every patient that comes into my practice, whenever I first see them as a new patient, I get dynamic imaging, X-rays, flexion, extension, lumbar, cervical, whatever the case may be, just so I can try to appreciate, like, what does that patient look like in flexion? What does that patient look like in extension or weight bearing? Because MRIs and CTs are done typically with non-weight bearing when the patient's flat in one position, and dynamic imaging of dynamic MRIs and CTs are very difficult to get. So a lot of times I like to kind of interpret what I'm seeing on X-ray and then translate to what that may look like when I look at their MRI. What does that look like potentially as a weight bearing image or as a flexion image? And it takes a little bit more thinking outside the box that I think what a lot of people are maybe accustomed to doing.
and in terms of subtypes of Ehlers-Danlos syndromes, are there certain ones that you think that you see more frequently than other subtypes?
Oh, that's a great question. To be quite honest with you, most patients that come to me don't really have a type or subtype. I think I see a lot of underdiagnosed or misdiagnosed or just not diagnosed patients. So I'm not, it's very rare that someone comes in and they know their subtype.
Mhm.
It's usually me being like, I think you've got a connective tissue disorder. I think you have EDS. I need you to go get screened.
Sure. And what would be the things that you would see in the exam, in the history taking process that would make you say that to somebody?
A lot of times it's people that have gone underdiagnosed or misdiagnosed for a long period of time and don't have the answers but have real pain. And so, it's looking at those patients with certain body habits or certain body types, real, skinny, long neck, a very tall patient. Not and that's just a very stereotypical appearance, but looking at patients and asking them those questions, do you feel like you are a little bit more bendy than normal? Like, do you have any issues where you've had subluxation of your joint or something like that? So those are all things that I try to ask patients whenever I have a suspicion of something that, may be going on.
Mhm. Yeah, and that stereotypical body habitus is so tricky because in my practice, which is of course mostly people with EDS or HSD, mostly hypermobile EDS, I should say specifically, or HSD, there's a lot of people that do fit that stereotype, but then I have lots of people that don't. So yeah, it makes it tricky. And of course, if they really have the arachnodactyly, long fingers and toes, and pectus abnormalities and things like that, sometimes we would suspect, well, maybe if they have Marfan syndrome or some other hereditary disorder of connective tissue. Do you find yourself, because I know you're more aware of these conditions than by far, most neurosurgeons, do you find yourself sometimes referring these people to geneticists, or if you're to refer them to somebody else, would it be PM&R? Would it be genetics? Who would it be most commonly?
Typically, I'll refer a couple patients per month for genetics. That's usually my go-to. I've found that at least maybe just region specific to where I'm at, if I refer them elsewhere, I just tend to not get a whole lot of anything.
Mhm.
So, I hate to send patients further down the line to feel like they're drowning. So I want to try to get them to where, but, geneticists is the backup for that. It can be a long time. They can wait sometimes 6 months, 12 months for an appointment. So I try to reassure them, hey, we're just trying to get you answers. It's not necessarily going to maybe change what we do, but I think you need to hold on to that appointment so we can maybe get some clarity to the situation.
Yeah, I know people who, have to wait years, so that's really, really challenging, and I'm sure when you are operating on people, you wanna know, are they more likely to have, the tissue fragility? Are they, more ligamentous laxity? I mean, might they even have vascular fragility? And so that's obviously really, really important. So, what do you see in terms of those kinds of things? Do you feel like now that you're so more aware of this, are you able to kind of, predict, pretty well, or how do you think that works?
Yeah, I think able to give a good guess if I think someone has some type of connective tissue disorder and then handle that situation. Is confirming the diagnosis going to change my treatment plan? A lot of times, like knowing or not knowing, not necessarily. Like if I suspect they may have vascular problems, that's a whole different ball game and a referral pattern I may take to kind of judge pre-op, risk stratification and that kind of thing. But in terms of wound healing, I think the question is, are they a surgical candidate or not? Do I think surgery is going to help them or not? And there are ways that we can mitigate risks with wound healing and stuff like that. And the biggest thing, with hypermobility disorder and surgeries, we often resort to fusion, and fusion has a high risk of non-ute, and then people with connective tissue disorder because they don't heal their skin, they're not gonna heal the bone. So we just kind of have to do everything in our power, use instrumentation, products for bony fusion and stuff like that that may be a little bit more hyped up than we would traditionally use, or take more steps to help provide patients the best, end game, the best result.
And so I know it's hard because it's not like you have all these patients that are coming in that are saying, I have EDS, or I have, I mean, I'm not surprised to hear you say that. But of course, the way I was going to ask a lot of these questions is like, well, in your EDS patients, so we'll just assume that we're talking about the people who you suspect that they might have EDS. And I'm curious if you notice any particular patterns of problems in people with suspected connective tissue disorders. Like, are you noticing a difference in their degenerative disc disease, spinal instability, other deformities, other things like that?
Um, in terms of spine, I mean, we see a lot of sacroiliac dysfunction.
Mhm.
I see a lot of that in my practice, just baseline, because I think being a female provider and SI disease being a female condition, I over proportionately see that. I'm also like one of the few providers in our region that really offers SI joint fusion as a solution.
Mhm.
So I'll often get patients that come to me with connective tissue disease with either, diagnosed or undiagnosed SI joint dysfunction. Spondylolisthesis is a really common problem that we see in EDS, particularly at like L4 and L5. That's the most common level we see just at baseline, but particularly, in patients with connective tissue disorder, that first level, that segment right out of the pelvis, which takes the most motion, the most stresses, tends to be affected. And that's why those dynamic films that I mentioned, those collection extension x-rays and that type of stuff is so important to get on those new patient evals so you don't miss something. I don't see a lot. I'll say, on socials and stuff, we see a lot of patients with hypermobility talk about like OCI dissociation and that kind of stuff, the instability, craniocervical instability. I don't see a lot of that in my practice for whatever reason. Um, Hyper aware of it, but I don't know. Yeah, I think that's less common, at least for me.
Mhm. Well, I think there's a few people that are probably like published a lot on that particular topic, and so I think that there's, if it gets to that point, but of course, there's a lot of people that have mild craniocervical instability or cervical instability that they're managing, non-surgically, and I think that oftentimes, if they do need surgery, they might be going to, a couple of people in the US that really specialize in that. And so I was curious about with the spondylolisthesis, just for people who don't know, that's when the vertebral bodies are slipping on each other with flexion and extension. And I'm holding my hands up right now for the purposes of the people watching the video. Would you say that's a pretty accurate description, or do you want to add to that?
Yeah, no, that's how I describe it. It's like, if you have one bone, another bone, they should be lined up one on top of the other. But in a spondylolisthesis, they translate differently. They don't hold together correctly. So it hurts.
Yeah. And I love that you do a lot with sacroiliac joint dysfunction as well, or you're able to do a surgical fusion, which of course, same thing with fusing any part of the body. Like we don't take that lightly, right? That's a very, very significant type of surgery. But it's great that you're able to do that as well, because I feel like the more tools that you have in your toolbox, the better it is for the patient, rather than they have to make sure that they have the right condition coming in to see you in the first place. Whereas it sounds like they might come in thinking that their problem is spondylolisthesis, but then as you're assessing them, you might say, no, I actually really think it's SI joint dysfunction instead. Am I correct about that?
Yeah. We often see SI joint pain and L4-5 potential pathology overlap a lot in how they present. And it's so difficult. I mean, I've been definitely operated on people that I was convinced that it was their spondylolisthesis and they have persistent pain after
Mm.
fixing that, and it's SI joint pain, or vice versa. We think it's SI, but it's really like a little annular tear at L4-5 or something like that. So it can be a little challenging, and even in the best diagnostician's hands, it's not always a perfect science.
Mhm. Yeah, definitely. And I know, having been on the patient side and the clinician side, it's also hard because a lot of times when you're asking questions, like I feel like sometimes I have a hard time answering. Like I don't know. I mean, it feels like this, but then so when you're doing your history portion, the physical exam I feel like might be a little bit easier. But when you're doing the history portion, well, what makes it worse? What makes it better? Aggravating and relieving factors, I think, are sometimes hard for people to really identify or sometimes describe. And what are other diagnostic challenges that you face with this population, would you say?
I think the biggest thing is just getting over, like, a lot of them have this, I don't know, fear of the healthcare system because they have been either gaslit or not had the right diagnosis made, or feel like their pain isn't worthy.
Mhm.
So I think that's the biggest challenge, is just earning trust and trying to offer real solutions to a very difficult problem.
And we talked earlier about, the quality of the ligaments and the vasculature and the quality of the tissues. How do you assess preoperatively somebody's risk of bleeding, whether or not they have hypermobility, if they might be at risk for wound healing problems, et cetera?
I mean, it's if you know going in that they have EDS or something like that, like, you're going to pay particular attention. But I really try to rely on, okay, have you had surgery before? What complications have you had? How did they deal with that? How did you heal? Did you have a wound infection? Those kinds of things I ask of every patient. But it's particularly important in those patients where, we're trying to make sure that we are stratifying the risks. And sometimes, I mean, in some patients with a lot of risk factors, and they maybe need a scoliosis surgery or something really big. I mean, is it really worth the risk?
Mhm.
And those are difficult conversations to have, because you're doing a multi-level scoliosis correction. Are they really going to heal the whole construct? And is it really worth taking this? Because sometimes, even though we're surgeons and we have fixes, sometimes things don't always aren't worth fixing, because you can put them in a worse situation if you didn't do anything at all.
Mhm.
So those are challenges that we that require a lot of insight and thought, and communication with the patient.
I love that you just said that, because I have said forever that patient selection, when it comes to surgeons, patient selection is everything. And back when I was doing anesthesia back in Wisconsin, we all knew, people who worked in the operating room, you knew which surgeons were, likely to operate on people, have kind of like a lower threshold, and which surgeons were very selective in who they operated on. And I actually, one time after I moved to Colorado, I've gone to a number of different people's practices and kind of hung out with them for a few hours just to get a sense of what people were doing. And this one orthopedic surgeon, there was this patient that was arguing with him, and he was telling her that he did not think she was a good surgical candidate. And it was just so ironic because he spent more time with her than with anybody else, and everyone else got offered surgery, and she was being, turned down for surgery, and she was really upset. And I get it, because of course, if you get to that point, right, you're thinking often that is the answer. But I really respect surgeons who are thoughtful in their selection process, and really thinking through the risks and making sure that the person is a proper candidate.
Yeah, I agree.
What about non-interventional therapies? Are there ones in particular that you often will recommend?
I mean, I think it depends on the problem. I think education is so important because, like you kind of touched on a little bit earlier, there are patients that have pain and discomfort that, like, maybe aren't either the best operative candidate or maybe just don't yet quite have operative pathology. But it's so easy to want, like, have pain and want to fix, but
Mhm.
it's not always like A needs B. And talking about taking the time to talk about those conservative options, whether it be strengthening with PT or traction or medical management, injections, alternative treatments, um, are those conversations sometimes take longer than surgery
Yeah.
and or surgical discussions, and patients maybe aren't some patients aren't as receptive to that because they want to fix. And it's just really trying to, again, explain why you feel that way so they understand and they know that might be their best choice or best outcome.
Mhm. I think that's one of the most challenging things is, there's people walking around that, you do imaging on them and they have all kinds of abnormalities, but maybe they don't have pain. And then there's people who have lots of pain and they may or may not have, corresponding imaging, abnormalities. But then it's also hard to know, like you just said about the pathology maybe isn't there quite yet. You want to make sure as a surgeon, of course, that those changes that you're seeing are actually explaining the symptoms, right?
Exactly.
Yeah, I just wanna make sure that people understand that, because I feel like it's just such a I feel like that's just such a key concept, because you can have a certain set of symptoms and you can have a certain set of findings, but that doesn't mean that one causes the other, right?
Right. Right. Yeah. And that's the challenge for the surgeon, the physician, whoever's making the diagnosis is we often like try to diagnose the imaging and you can't do that. You really have to, and it takes a good physician, a good listener, and a good diagnostician to like be able to put the two together and even the best, like I said earlier, the best ones still make mistakes. But
Right.
it's even more challenging in this patient population.
Yeah, definitely. And speaking of this patient population, are there any of the standard surgical techniques that you use that you modify? So we talked already a little bit about fusion. If you're doing any kind of other fixation, instrumentation, grafting, are there things that you might modify in that regard?
Yeah, so I'll try to, there's different products, especially in spine fusion, like that we can use to augment patients that we think that are at risk for non-union. So different, you know, like we might use a certain type of bone graft or over another, or we might use a bone stimulator. But in a traditional setting, insurance may not cover that because it's
Mm,
not, doesn't meet the criteria. So you have to kind of explain why I think this patient needs this product because of this reason,
mhm.
and really going to bat for them to make sure that they can get what they need to give them the best chance of avoiding a pseudoarthrosis or a non-union, which would potentially lead to more future
Right.
surgery.
Right, right. Oh, and the insurance piece is so I don't know why I called it the insurance piece. It's not like it's a piece, but dealing with insurance companies is so frustrating.
Yeah,
Yeah.
but it's a part of reality of healthcare, at least here in
Mhm.
the US right now.
Yeah, absolutely. And it is frustrating because, like you just alluded to, there might be something that would cost less money, but look be on the more preventative side as compared to waiting until you have the non-union and need another surgery, which is going to be a lot more expensive. But in general, insurance companies, it seems like they really struggle with that more preventative type concept.
Yeah, for real, they do. I mean, because prevention, they're a business too. So like
Mhm.
prevention, does that prevent them from having to deal with that cost in the future? Or are they actually paying now to prevent it for another insurance company in the future? So they don't think that way. It's a different mindset, and it's a little frustrating.
Mhm. Okay, I think we're gonna take a quick break, and when we come back, we're gonna talk about prognosis and what we think the future might hold, in this space. We'll be right back. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again and enjoy the rest of the episode. Okay, we're back with Dr. Grunch. And I'm curious, we've obviously kind of been talking about fusion, and we talked about sacroiliac joint fusion and fusion for spondylolisthesis. What are some other surgeries that you think that you've performed in patients that might have connective tissue disorders, whether they have a formal diagnosis or not? What are some other things that you might be operating on people for? What would be the condition and the indication for the surgery, and what would be the actual surgery that you would be performing?
Yeah, I mean, we touched a little bit on joint disease and spondylolisthesis in the spine, but often, scoliosis is something that can affect people with connective tissue disease that may be underdiagnosed or misdiagnosed. And those are even the more challenging cases because those are higher risk, especially in the non union setting. Like if they don't go on to fusion, trying to fuse 10 levels of the spine and you're a high risk, then inevitably speaking, if one level doesn't fuse, that patient could not have a successful operation. So those are the ones that really give me the most heartburn, to be honest.
Are you doing that very often?
I do a fair amount of deformity work, yeah, in my practice. I probably do 1 or 2 a month,
Mhm.
which is a pretty high amount for a spine surgeon.
Mhm, mhm. Yeah, those are big surgeries. So you're talking about scoliosis where, I know you can't say like, "Oh, there's this magic number for the curvature," but might be some indications for scoliosis surgery?
Typically speaking, I mean, we look at like an angle of 30 degrees as their Cobb angle is something that we would really consider being in a area of needing correction.
Mhm.
I mean, but that being said, I mean, there's patients that have less than that we offer surgery to. But that's kind of the number that's tossed around in the literature.
Mhm, mhm. Okay. And I know back when I was in the operating room for neurosurgeries, it's been a long time since I've anesthetized someone for like a big Harrington rod surgery or something like that. But how do you do a repair now for scoliosis? Because I know I've had some people talk about some, much more minimally invasive type of surgeries, but I don't know, what the current standard of care is.
Yeah, I mean, we definitely don't do Harrington rods anymore, thank God. Yeah, I mean, the biggest thing for deformity correction is trying to restore the most natural alignment to the spine. So we talk about coronal and sagittal balance. So that's like if the patient is standing up and you're looking at them straight on, like are they curved to the side? That's the coronal balance. And the sagittal balance is looking at them from the side. So does their head sit over their pelvis? Is it too far forward? Do we need to correct the lumbar lordosis or pelvic incidence draw numbers we calculate? So a lot of statistics, physics, and math that goes into correcting some of these deformities because we know that overcorrection or undercorrection could potentially lead to further problems down the road. And if they're a young patient, we want to try to get them as perfectly corrected as possible so they don't have, hopefully, future issues with their spine in 10, 15, 20 years down the road.
And in terms of patients maybe that you're not referring or not recommending that they proceed with surgery, do you ever recommend something like Schroth physical therapy? Do you find that to be helpful, or are there other modalities or bracing or anything like that that you are often recommending for scoliosis?
Yeah, I mean, I talk a lot about core strengthening and pelvic floor strength in women or in men for that matter. I tend to see it a lot more in women's health, but um, yeah, I mean, those things are very vital to helping with the symptoms of scoliosis or anything really, just to get your spine in better conditions, weight bearing exercise, um, and those types of things are crucial because when we're hurt, we don't necessarily want to do those things.
Mhm.
But it's like a dangerous cycle that happens. We hurt, we don't exercise, we don't strengthen our body, then we get weaker, then we rely more on our joints. And then those joints aren't good, they're hypermobile. So then you're just in this continuous detrimental cycle to yourself.
Mhm. Yeah, it's really, really challenging for sure. And in terms of sacroiliac joint fusion, and coming back to that again for a second, I want to just ask how often after you fuse one side, do you end up having to fuse the other side?
I mean, gosh, it really depends on the patient. It is a often is a unilateral condition, but in a large majority of patients, it can be bilateral. The interesting thing is, I used to in the patients that I knew had bilateral SI joint pain, I would just fuse both sides, but it's really hard in the recovery because at least in my practice and in my outcomes, I've seen better recovery if I'm letting them baby that side in their healing process. So, like partial weight bearing, really trying to minimize load on that joint that you just fused. And you can't do that if you fuse both sides. So, I saw a higher risk of non union when I was doing both sides at the same time. So, I switched to doing just one side. Let's do the worst side first, let you heal 6 to 12 months later. We'll come back and do the other side. But
Mhm.
what I found was that in a large majority of patients where I did the one side, the other side almost like compensated or balanced out, and they didn't necessarily need that side done. So it's fascinating. I mean, I won't say that's the case for every patient because we will go back in and fuse the opposite side in many patients, but it's interesting to see how sometimes fusing one side can almost correct the other side or maintain it in balance or in alignment.
Mhm. Well, that's great if there's some people that can avoid doing that second side, and I've often thought that when people this was rare, of course, but every once in a while, you'd see somebody come in for bilateral total knee replacements, and you're like, "Oh my gosh."
Yeah, no, please.
Yeah, no, thank you. I mean, I get that, you have one horribly painful recovery period, but that just sounds really, really awful to
Yeah.
me. I'm curious to ask your take on chiropractors because, of course, it's a whole field, right? I mean, it's a whole lot of people that have some standardized training, and they practice so differently. Though, I mean, there's the people that do the NUCA type of chiropractic, and specialize in like the upper part of the cervical spine, and doing all kinds of very very specialized treatment there. But it's also hard because there are still chiropractors that do some more aggressive type treatments. So I would love to know your opinion about chiropractic therapy, in particular for people with a possible connective tissue disorder.
Yeah, I mean, chiropractic medicine it's easy to kind of ball it up into one, but I mean, it can be very useful in patients, but it can also be harmful. So it's there's not a lot of, unfortunately, it's not a very evidence-based field. And, we need that to make clinical decisions and patients with connective tissue disorders that are kind of set up for that. Like, I'm going every avenue possible to try to help my pain. I hurt, but the healthcare field is telling me I shouldn't hurt. So I need to go here to try to get help. But go into chiropractic field if they have, vascular pathology or more prone to dissection, going and getting the high velocity neck manipulation could be, I mean, it could kill them. I've seen it before. So it's so challenging. It's on the onus of the chiropractic profession to recognize that these patients and the challenges they face in traditional modern medicine and resorting to chiropractic treatment, wanting to help them, but also knowing the risks of manipulation. That's where they can get themselves into trouble too with really hurting people because they, are more vulnerable to either spine or vascular injury with any type of high velocity, manipulation or whatever the case may be.
And in terms of, I don't know how often you see this, patients that have loss of the cervical lordosis, so, loss of the natural spine curve in the cervical spine. I know there are some chiropractors who like specialize in restoration of that curve. I don't have enough data myself to know if they are often successful. Do you happen to have any opinion about that?
I mean, I'm not seeing any good data to suggest that anything that you can do from a chiropractic standpoint can really fix reliably deformities.
Mhm,
So, I mean, we see it a lot on social media and things that go viral and stuff like that. But like the reality is there's just not a lot of evidence to back that proclamation.
mhm.
And you just have to tread that very, very lightly if you're a patient. I mean, you deserve to know like what your risks and benefits are and what is the data behind that and how are you going to help me and is this worth my time? Is this worth my money? And is it and those are and time is money, really. So you need to be able to know what you may expect from any type of treatment.
Absolutely. And if they can take something that maybe is slightly out of position and improve the position, but it doesn't stay, it doesn't hold, then, are you any better off than you were before?
Yeah, exactly. Exactly.
Okay, so getting back to surgery, we talked quite a bit about fusions and how important that is to have, to actually be able to form that union between the bones. Do you ever use cadaver bone or other things like that?
Yeah, all the time. I mean, cadaveric, DBM, or whatever the case may be, allograft treatment is the mainstay of grafting for spine.
Hmm.
There's other things we use like autograft, so patients own a bone that has their own stem cells in it that can lead to a higher success. There's other products like I Factor or Infuse that have a higher concentration of hormones in that product that can augment or like kind of put gasoline on the fire of a fusion that wouldn't be natural in cadaver bone or their own bone. And those products are more costly and sometimes aren't necessarily covered. So yeah, there's a lot of things, and some of them have risks. So Infuse, for example, carries a black box warning of increasing your risk of cancer. So
Mm.
you have to be careful.
Yeah.
Yeah.
Wow. And these are tough decisions for patients to make. I feel like, we now have patients have so much access to information, they can go online and they can look at, a large number of papers because of course a lot of things are open access now that they weren't when I was in school. And more information can sometimes be it's a great thing in a lot of ways, but also can be really overwhelming. And then you feel a lot of responsibility as the patient. So I'm curious to ask also, are there any tips that you give people preoperatively to help with the fusion process in terms of like nutrition or other things that they can do to maybe improve their outcomes in that regard?
Yeah, nutrition is important, making sure that you're eating as good of a diet as you can. It's like protein heavy, things are going to give you good healing properties in the healing cascade. Activity modifications are important, like listening to what your doctor says to do and not do, brace or not brace, or whatever the case may be. It's very important. And then, things like nicotine cessation, incredibly important to talk about in patients, no matter what their disease process is, because that can lead up to a 50% failure rate. And those are things that we don't even talk about. Operating on a patient when they're at the right body weight. I think those are conversations that are difficult to have. Diabetics, making sure that their glycemic control is good. Screening for osteoporosis. Or is their bone quality good? Those are all things that, at least in my mind, not my mental checklist on every patient I operate on, that I go through in my mind and make sure I'm asking those questions.
Mhm. Yeah, that's really important because you're wanting to set them up for success, which is great. I do remember back when I was working in Wisconsin, there was one of the neurosurgeons that would do, I can't remember if it was a urine test or a serum test, but they would check for nicotine
Yeah.
and
Usually
cancel the
blood test.
and cancel the
Yeah.
case if it came back positive. They would cancel the case the day of, so
Yeah, I mean, I'll do it pre-op. I don't like to cancel cases day of surgery because it's just so much stress on the system that's prepared. But I ask everyone, I screen everyone. If they're positive, we cancel it ahead of time.
Mhm.
If they're negative and you had a suspicion, sometimes you have to check a day of surgery, but that would be unfortunate.
Mhm. And tell me a little bit more about the body weight, picture, because I feel like I'm very aware of that when it comes to total joint replacements and the risk of wound infection and DVTs and things like that, or deep venous thrombosis, blood clots in the legs. Um, Tell me more about what your process is.
And there's similar data in the spine that higher the BMI, the more likely for wound infections, non-union, which is crucial, the recovery and their pain and their experience. So in our approach, so in spine, it's not like a joint replacement. You do it the same way every time. In spine, you can come anterior, you come lateral, you could come oblique, you could come posterior, like different ways of getting to a particular level. There's different implants that we use depending on the approach. So, like an anterior approach, you're going to get the biggest implant in there, which for someone that's overweight, may be best because you want more surface area
Mm.
for fusion. Um, but, also then being overweight is very challenging to get there safely. You got a deeper area, more tissue to go through. And again, those are really important issues that you need to be transparent about. And I think these conversations are a little easier now in modern medicine, at least in the past 2 years, where I can say, hey, I'm very concerned about, I think you need surgery, but I'm very concerned about your rest. So why don't let's talk about Ozempic or Monjaro or something like that. Those are easier conversations than they were a few years ago when you're like, I know you hurt, but we need to work out.
Yeah,
Like it's,
right,
yeah, yeah.
right.
So
And And that's a great transition because I just wrote down GLP-1s, because I remember you had a post, I think, a while back about, GLP-1 or glucagon-like peptide, receptor agonist medications, which you just mentioned a couple, tirzepatide, semaglutide, there's quite a few available
yes,
now. Um, and you were posting something about those medications and intracranial pressure, I believe. Is this ringing a bell, or could you
yeah,
comment on that? Yep.
yeah. So GLP-1s actually change the way our body brain produces CSF, which is fascinating.
Mhm.
So those medications can reduce the amount of CSF that you produce. So we knew that patients that are on GLP-1s and they have pseudotumor cerebri, increased cranial pressure, they got better, but it wasn't because they were losing weight. The effect was quicker than the weight loss. And
Mhm.
so the scientists, figured out that it was actually altering or reducing the way spinal fluid is produced, which is amazing. I mean, that's a breakthrough that can really help people tremendously that are suffering, and maybe patients that aren't necessarily that have this problem that aren't overweight,
Mhm.
maybe qualify to get them approved for these medications that could help them.
Mhm. Yeah, and I've had a lot of patients say that they got started on GLP-1 and it really helped stabilize their mast cells, and I know in the literature there's a case report, and there was another study that came out fairly recently. It's not like there's a ton in the literature about this yet, but anecdotally, I'm hearing from quite a few patients, a lot of patients are of totally normal body weight, or even maybe their BMI is a little on the lower side, but they're being prescribed these medications for mast cell activation. And I'm hearing some positive things from a lot of people, generally much more positive than negative. I think I have only one patient who just really couldn't tolerate even a low dose, but it's really fascinating. And they're also started though at like 1/10 the usual dose, like it's really, really low, often from a compounding pharmacy, and kind of titrated up. So that's also really interesting in this population, especially. And a lot of people have been prescribed acetazolamide for
Yeah.
the similar problem. So how would you compare and contrast those two options?
Acetazolamide is riddled with side effects, so, it's very difficult to find someone that can really tolerate that very well, and it's the mechanism of action is different than the GLP-1, so, I think it's just, it's I mean, obviously, it's a little easier to come by, and they both have good data to help, but I think you're gonna have more side effects in the patients that take acetazolamide than the GLP-1s, and the benefits just keep rolling out with those medicines. It's really interesting. I mean, I know they get a lot of some negativity, but, the cardiovascular benefits, all these other things that are coming out about, how it can help is very interesting to see the future and how, these medications hopefully can make us healthier humans.
And when should a patient with EDS or a, possible connective tissue disorder, when do you think that the right time is to seek an evaluation from a neurosurgeon?
I mean, that you could seek an evaluation anytime you want, but you need to be able to make reasonable decisions because there are surgeons that, like you said earlier, like their risk stratification isn't good, their patient selection is not good. And just because someone says you need surgery, do you really need surgery?
Mhm.
So I think it's always good to get ideas and thoughts. But if you're making a decision on something that could alter your body forever, you really need to take that into deep thought, get multiple opinions. You know, it's just, I've seen a lot of patients make the wrong decisions about surgery and then end up suffering. And then there's nothing that we can do once it's been done, which is
Right.
hard.
Yeah. No, really hard. And what about Tarlov cysts? Is that something that you operate on, or have you seen very often? What are your thoughts about that?
Yeah, I mean, we see them a lot, just incidentally speaking. Um, Tarlov says are something that is found on MRI reports a lot. And there are patients that are symptomatic from it, and there are patients that are not symptomatic from it. There are patients that um, you get on the internet and you'll find so much stuff about it. And it's challenging. And I don't know if I have a grand solution here. Have I operated on them? Yes. You can see perineural cysts or Tarlov cysts on a nerve root that's compressive and causing problems. But for every one of those, I think you'll find 10 times more that are just incidentally found and not really causing issues. And it's challenging. Again, going back to what we said is people want a solution and maybe that just isn't really causing the problem. I know there are some specialists that really focus on this in their practice, and I've had patients that have gone to Texas and had that surgery done and done well, but I've also seen patients that have gone and had it done and end up developing arachnoiditis or something 20 times worse.
Mhm.
And so it's definitely, definitely a very delicate topic.
Yeah. Yeah, and I'm glad you mentioned arachnoiditis because I definitely wanna circle back to that, but I do wanna ask, because I've had surgery actually for Tarlov cyst, and I had, a block beforehand, a selective nerve root block, to determine if that Tarlov cyst was likely the causative factor in my symptoms. Is that the approach that you would normally take to help determine if that Tarlov cyst or perineural cyst is symptomatic or not?
Yeah, we can use diagnostic injections, but usually Tarlov says they're down the sacrum.
Mhm.
So it's going to be challenging to do a nerve block, S2, S3, those kinds of things. So, um, uh, the ones that are easier are like, if they're on a motor neuron or causing radicular pain or something like that, those are a little bit easier to diagnose. Those are the ones that I've had the most success with either pre-op injections or just going in there and fenestrating the cyst to see if the patient gets better.
Then let's talk a little bit about Cauda equina syndrome, because I feel like, I have this very, very complex patient population, and every once in a while I'll get a message in the portal. I suddenly lost the ability to hold my urine, and it's not, just a little bit of stress incontinence. It's like, no, my urine is just like coming out, and or stool incontinence, which, you know, ordinarily, and what I was taught was, this is a neurosurgical emergency.
Yeah.
But a lot of these patients have had so many problems, and I feel like even if they go in emergently to the ER or something, that they may or may not get a, prompt evaluation. And if they do an imaging study and they see, oh, you have a Tarlov cyst, but nothing else, that they often are, kind of sent home without really any kind of an action plan. I've had several patients who had Tarlov cysts and also had, saddle anesthesia and incontinence and things that we normally would, associate with Cauda equina syndrome. Can you comment on that a little bit? And I guess I didn't really describe, other than what I just said, about what Cauda equina syndrome is.
Yeah, Cauda syndrome is where you have compression of any of the nerve roots going in the low back down to the sacral area that can cause a constellation of symptoms like numbness in the groin, perineum, urinary and bowel incontinence. So those sacral nerves get impinged from compression. That's a neurosurgical emergency because those nerves are so delicate. They even compression for a very brief period of time can lead to permanent issues with sexual function, with the ability to go to the bathroom on your own, which, as we know, is life changing.
Mhm.
So those diagnosed and the patients can have incontinence for a multitude of other reasons. So it's a slippery slope of like, did you have pain really bad and so you urinated on yourself? So I mean, the easiest thing to do is if you have that is to get evaluated because those symptoms in the combination with the compressive pathology is a neurosurgical emergency.
Mhm.
In the absence of imaging, it's not um, an emergency. It could be representative of something that's totally different, another cause. But it's so you don't want to ever brush something off that could potentially be make the wrong choice, wait a day, and this is how it's going to be.
Right.
Um, and those are the ones that call my office, say those symptoms. We know they got to go to the ER, whether or not it's real or not real. We got to see.
Mhm, mhm. Right, because if you can relieve the compression, then you can potentially reverse those symptoms, but if you don't relieve the compression quickly enough, then, like you said, the changes are gonna be permanent, so,
Yeah.
yeah, yeah. Are there other neurosurgical emergencies that you want people to be aware of?
I mean, the biggest thing is just dissection and stroke.
Mhm,
I mean, I think of brain health out and spine health together. So, um, making sure that you don't subject yourself to a risk of getting something like that, like going to the chiropractor. But to be honest, you can get a dissection from doing anything. You can get a dissection from throwing your head over and brushing your hair upside down. So, any types of neurological changes that are different for you. You know your own body and the best. You're your own advocate. And if you know something is different or wrong, you got to get it checked out. And it can be hard because sometimes you maybe don't feel like you're being listened to.
mhm.
And you just have to be the best advocate for yourself that you could be.
Yeah, a lot
And
of
that's,
people have had so much gaslighting that they are afraid to go to
They're
the ER, which
scared. Yeah.
I get it. I get it. I totally get it. Yeah. Let's come back to arachnoiditis before we're ready to wrap up. Can you, you just touched on that briefly as a potential complication from spine surgery. Can you define that for us? And what do you want patients to know about arachnoiditis?
So arachnoiditis is where, your nerves typically float around in your lumbar area like little spaghetti noodles in water. And arachnoiditis is where they don't float anymore. They can stick or scar either to each other or to the dura. And our body is meant to be, our body is in motion. So anytime we walk, kick, move our legs around, the nerves slide up and down and glide. But if they're stuck or scarred, it can cause problems. It can cause pain. It can cause weakness. It can cause numbness. It can cause Cauda equina symptoms. And it's it's a little interesting in how patients can develop arachnoiditis. I mean, usually it's not just spontaneous. Usually it's from something that causes inflammation around the area. It could be infection. It could be bleeding in that area. It could be from a regular injection that you get. Epidural or a myelogram, maybe a test that we're in medicine where we inject something into the spinal fluid space, but your body has a bad reaction to it and swells up, and then you get arachnoiditis. So I think it's just knowing the risk of that, knowing that that's a known entity that again can be misdiagnosed. Is knowledge is power. So, knowing what those things could be, and the worst thing about arachnoiditis is it's progressive and there's no cure, and there's not a lot of treatment for it, and it sucks. So that's the hardest part for me making that diagnosis is knowing, okay, now we know this. Now what else can we do? There's neuromodulation, spinal cord stimulation that can be an adjunct, um, and meds and other things like that, but it's still very difficult.
Yeah, these patients are really, really suffering. And I've ended up with quite a few patients because when Dr. Forrest Tennant, who has done so much research in this space, when he closed his practice, I was on his short list of people that he was recommending people to. So I have a number of arachnoiditis patients in my practice, and I just
Mm,
take a general anti-inflammatory type approach. And
yeah.
I follow his bulletins and things like that. And with a lot of the things that he recommends, might be some hormonal therapies and things like that. It's like, well, it's worth a try because, like you said, it's not like we have a lot of great double-blind randomized controlled trials that tell us that, ABC is we don't have a drug for that, at least not yet. So, yeah, no, that's a tough condition to have for sure. How often do you see tethered cord syndrome, and or CSF leaks?
Tethered cord we don't see a lot of in adult medicine. It's just not very common. It's usually in the spina bifida patients that get cycled around in the pediatric world. Even as adults, they tend to still stay down there, but we will see it from time to time.
Mhm.
It's just usually if it remains asymptomatic throughout adolescence and that growth spurt, it's less likely to be a problem in adulthood. And what is the other thing you asked me about?
CSF leaks.
Oh, CSF, like again, fairly rare, but it's very difficult to diagnose, and you have to be kind of astute to be able to have that even in your thought process or differential to know if you think that patient may be suffering from that. But um, it's important to either, like, if we're talking about it through the nose or somewhere where it's actually visible, that's hard to not diagnose it. But those spontaneous CSF leaks from a nerve root cyst or sleeve or something, those are so hard to do,
Mhm.
to diagnose. And I think those are the most challenging ones.
Mhm. And then you get to the point where you have to decide, do I have a myelogram or not? Now, doing something that may put me at risk of arachnoiditis, which some of our arachnoiditis patients definitely had myelograms, which again doesn't prove cause and effect for sure. And speaking of cause and effect, really quick, last question before we move on to the hypermobility hack. So, are you saying that in some of your adult patients, you might actually see a tethered cord, but you don't But it's not symptomatic. You see asymptomatic tethered cord sometimes?
I mean, I guess you would see them asymptomatic and someone has a low-lying conus or something like that. That's pretty rare. I would say patients that have like symptoms of tethered cord are usually pretty rare in adulthood because if they do have symptoms or tethering of their cord, they're usually going to present during that growth spurt. But I have had a few patients that I think were symptomatic, or maybe they had it, they weren't symptomatic, but then they got degenerative changes or something going on in their spine that tipped them over the edge.
Mm.
And so those are some things that we see that's pretty uncommon, but you see them. Um, if you see horses, you also see zebras. You just got to recognize them.
Yeah. Yeah, definitely. And unfortunately, that's something that zebras tend to get more of. If you have a connective tissue disorder, then your risk of tethered cord definitely goes up, like with a lot of these things. So, okay, great. Well, this is such great information, and we always like to end with a hypermobility hack. Do you have a hack for us?
Yeah. So like, I think it's easy in hypermobility patients to want to stretch, but I always talk about doing like strengthening before you stretch. So instead of like going forward to stretch in the morning first thing, and then go work out, you want to like kind of activate your core, activate those muscles before you stretch. So you don't overdo it. You don't like pull something. So I always like to, I mean, my go-to core strengthening exercise for everybody is the glute bridge because for most people, no matter how strong they are, how physically exertional are, they can do the glute bridge. And just doing that, that's where you lay on your back, kind of lift your pelvis up and hold because that engages those gluteal muscles, which we often don't do. And they're so important for your core strength. So doing that, holding it 3 to 5 seconds and lowering it down, repeating that 5 to 10 times. Also kind of auto aligns your SI joint and it fires those muscles that may help you is doing it before you get out of bed in the morning is important in activating your core and your
Mm.
lower abs. So yeah,
So you recommend doing that before you get out of bed?
yeah, before you get out of bed, or definitely before you do any type of like stretch, so you can kind of your body can your brain can engage and know the length of your muscles, so you don't over stretch yourself and put yourself at risk. There's all already loosey goosey joints, you're going to make them even more loose if you're not protecting them when you move.
Mhm. Yeah, and I know some people love to do self-manipulation. And, I should have asked your thoughts on that, but real quick, can you share your thoughts on self-manipulation?
I mean, I think it's a easy way. Like it's a almost like a habitual thing for some people, like popping your knuckles or popping your neck or whatever the case may be. And to just realize, like, am I doing that because it's like routine for me? Is that really doing anything to benefit me, or is it just like kind of this nervous habit that I have?
Mhm.
And trying not to 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 do those things that may put you again at risk for hurting yourself.
Mhm, mhm. Yeah, no, I view it the same way, especially because, yeah, you're like you said, some people, it's a habitual thing, so you're doing it over and over and over again, and, it feels good at the time, but it doesn't mean that it's actually beneficial for you.
Right.
So, okay, thank you so much for joining me today, and before you go, can you tell me if you have any special projects that you're up to, research that you're doing, anything like that, and also where can people learn more about you?
I'm on almost all social platforms on Lady Spine Doc is my handle. You can find me on most things, and yeah, that's basically it. I mean, my kind of like my thing now is I just launched like a boutique, ladyspinedoc.com, where I sell medical inspirational merch, and that's been kind of a new passion of mine. And done some designs for EDS and raising awareness and raising funding for conditions, so you can kind of, you know, wear what inspires you and wear your um, condition, but also use that to kind of help support a good cause.
Does that go to a nonprofit organization or
Yeah, yeah. So for the EDS design that I did, we had like a bendy baddie design, which was fun. I actually worked with one of my patient's daughters who is EDS patient and just got accepted into Harvard.
Oh,
And
wow.
she's a public health, she's very smart, very amazing person who also has these designs. So anyway, she selected it's a research institution for EDS. I'm blanking on the name right now because I wasn't expecting this
Sure.
question,
Sure. Sorry.
but yeah, no, you're good. But I always try to, at least make something substantial um, impact on the things that we do, so we can um, make a benefit. So
Yeah, no, that's amazing. I have a boutique. It's called the Bendy Bodies Boutique, and same thing where a large percentage of the proceeds go to the nonprofit EDS Guardians. So it's great
nice.
when we can do things like that. So
Yeah, exactly.
yeah. Well, thank you so much for joining me today. It was so great to finally get to meet you. I don't know how long we've been planning this for, but I feel like it's probably
Well,
six.
months.
Yeah,
Yeah,
I
yeah.
was gonna say,
I look back, it was like Christmas of last year,
yeah,
I
yeah.
think.
So I think it's probably closer to a year than 6 months even. So it's been a while. I'm glad we finally got to sit down and
And we
chat. And
almost weren't even able to do it today because of the connection.
I know, it's crazy. Literally, and I've done this podcast. Well, I initially did do it on Zoom, but then today we had to do it on Zoom instead of Riverside, which has not happened in the past year plus. That has not happened once, and it happened today. It's like just crazy. But anyway, thank you so much for taking the time to chat with me and share so much great information.
No problem. Have a good one.
Well, I can't believe that I finally got to sit down with neurosurgeon Dr. Betsy Grunch. We have really been trying to do this for a very long time, and I really think that this was such a great conversation. Neurosurgical problems are so common in people with connective tissue disorders like EDS, so it's great to hear another neurosurgeon's perspective. Thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. I have lots of other resources that I want you to check out, including my newsletter, the Bendy Bulletin. You can check that out on Substack at hypermobilitymd.substack.com. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. Did you know that I also offer one-on-one support for both clients and healthcare professionals? Whether you're living with hypermobility or caring for people who are, I've got your back. Check out my coaching and mentorship options on the services page of my website at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at HypermobilityMD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements shared on Bendy Bodies should be considered medical advice. Please always consult with a qualified healthcare professional for your own care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.